Welcome back to the Virtual Transplant Conference, Session 2. We are excited to recognize our sponsors who have made this event possible. Please give your attention to these short videos provided by Trio National and the CARE DX.
On behalf of Trio National, congratulations, Michelle and Marty Marin and your Trio Maryland chapter for putting together this fantastic conference adapted for the restrictions of pandemic year past. Great work. Anybody else would like to join Trio in making things like this happen? Go to our website at trioweb.org and sign up. You can make a big world of difference, just like Trio Maryland is with that kind of leadership.
My name is Stephen Potter. I'm a transplant surgeon at Baylor Scott & White Health in Temple, Texas. I want to take great care of patients with compassion and empathy. You have a chance to really be vertically integrated into the patient's care, follow them along, and learn about their stories and their families. And it's fantastic to see them get back to work and a healthier life after transplant. And obviously, as a surgeon, I want to provide the best possible technical outcome for them. Post-transplant surveillance is incredibly important and doesn't get enough attention because it's one of the keys to prolonging allograft half-life, or how long the patient keeps their kidney and stays off dialysis. Staying off dialysis adds years to their lives, it adds quality of life, so post-transplant surveillance is a critical issue. Donor-derived cell-free DNA differs from the existing alternatives because it helps us know whether there's rejection or inflammation in the transplanted kidney. It can lead to biopsy when otherwise biopsy wouldn't be obtained because it increases your suspicion that there's going to be rejection. It can also prevent unnecessary biopsies because a low donor-derived cell-free DNA level gives you very positive information that there's not going to be rejection in that organ.
A few housekeeping items before we begin. Recording. This webinar is being recorded. Recordings will be sent to all participants after the event. General meeting room. Chat face-to-face with other participants. This Zoom room will be open from 10 a.m. to 12 p.m. Eastern Standard Time. Link will be available in the chat box at the end of this session. Support. If you need support, please text 410-635-0229. Comments and questions. Please use the Q&A feature to ask questions, which will be answered by the speaker at the end of the session. Chat box. Please use the chat feature to communicate with other participants. This is a webinar format, and you will not be able to see or hear other attendees. Dermatology and Cancer Prevention, presented by Dr. Kristen Bybee. Dr. Kristen Bybee will be able to answer your questions, so please post them in the Q&A tab, and we'll be able to share those questions and answers as time allows at the end of the presentation. Dr. Bybee is a physician scientist in the Department of Dermatology at Johns Hopkins University School of Medicine. Her clinical practice is focused in Mohs surgery, complex cutaneous oncology, and transplant dermatology. Her scientific interests include mechanisms of skin cancer development and evolution in immune-suppressed patients, mitigating risk in high-risk cutaneous malignancies, and patient education. Welcome, Dr. Bybee. Please take the floor.
Thank you, Hazel, and thank you, Trio, for the opportunity to present today. I'm going to share my screen and hope that I have it in presenter mode. Hazel, does this look right from your side?
Yes, it does.
Okay, thanks. Okay, so thank you again for the opportunity to present and for all of you for tuning in. It's, I think, the perfect day for a webinar here in Baltimore because it's rainy and chilly outside. So thank you all for taking the time. I am going to talk about your skin after transplant. I am a transplant dermatologist at Johns Hopkins. I'm also a Mohs surgeon. So I couldn't help but notice in this stock photo that was presented as the slide to use for this conference that dermatologists just look at people differently, I think. I saw this woman here, the one that's in focus, and immediately was drawn to looking at her skin. And what I notice is a number of things on her that are benign spots, not worrisome spots. So you can see at the top, I've circled these sort of brown stuck-on spots, seborrheic keratoses. She also has lentigines, which are sunspots. And then down on her chest, she has what looks like evidence of lentigines as well as actinic keratoses. These are all items that we take care of in the dermatology side. And those of you that have seen a dermatologist may have heard of some of these in the past. So I just found it to be very interesting that this picture was the one that was presented and how I was drawn to think about her. So today I'm actually going to talk about a number of benign things that can happen to anybody, but tend to also happen in transplant patients and at a higher frequency. But I'm also going to talk about some more worrisome things that can happen in your skin, and your chances are higher after transplant for them. I have no financial relationships with any of the companies or products that I am discussing. And I do have a few photos from patients that I have treated. I also sought input from some of my patients that I take care of on the content of this presentation. So I just wanted to thank them for the thought and time they put in to make this presentation what it is. And I hope you all get something out of it. So we'll start off with things that I don't think are worrisome as a skin doctor, but they are annoying. And then I'll go on to talk about things that are worrisome as well as annoying, and then a little bit about prevention, and I'd be happy to take questions. Okay, so starting off with the things that are not worrisome, and I put the asterisks on there because it's not worrisome to me as a dermatologist. That doesn't mean that it's not worrisome to you as a patient, but these are things that when you come into my office, you get mostly reassurance about, that it's not problematic and not going to impact your health. That doesn't mean that there aren't things we can do about them if they're of a cosmetic concern, but are not things that we actually are concerned about decreasing potentially lifespan. So I've broken up this talk into the time after transplant and when I would expect certain things to come up, and that's what the timeline is at the bottom. So the first thing is acne. So many people have had experience with teenage acne and dealt with that. Some people have continued to experience it into their 20s, 30s, 40s, 50s, and beyond. But acne can be a particular problem in the post-transplant period. And the reason for this is that high doses of steroids are often used. And there is a phenomenon called steroid-related acne. So this is an example on a patient's chest of steroid-related acne. It looks just like the acne you would expect to see on a 13 or 14-year-old, except for it all tends to be in the same stage. It also tends to go away after the steroids have been tapered. So I tend to see this on patients that are on very high doses of steroids, like 30, 40, 50 milligrams of prednisone. And as the steroid gets tapered down, the acne goes away. But again, just like acne in teenage years, it doesn't go away immediately. So there's sometimes residual. We can treat this, and I usually approach it just like standard acne regimens with washes and topical therapies, like I would anybody who walks in with acne into our clinic. There's also this condition called Acneiform eruption, which is basically acne-like, and it is often due to sirolimus, the immunosuppression medicine that many transplant patients get put on. Most patients are not actually tending to be put on that immediately after transplant, so we may see this as a conversion is done later in their transplant journey. And typically, unfortunately, this is pretty non-responsive to topical therapy, and I usually have to use an oral therapy like an oral retinoid. The medication there would be something like acitretin or isotretinoin. You may have heard of isotretinoin. Its other name is Accutane. So we oftentimes have to use those types of medicines to really clear up this condition in patients. If it is related to a medication, oftentimes we can talk to the transplant team about which of the medicines we think is the driver, and we can decide together whether it makes sense to try to change that. So another problem that tends to happen in the first few months after transplant that is not worrisome, just annoying, is palmoplantar peeling. So that's peeling of the palms and soles. And this can be very distressing to patients because now you've made it through the stress of having the transplant, going through the whole process, being called into the hospital, and hopefully on your way home after the hospitalization and well on your way to recovering from the surgery. And then you find that you have this intense peeling, and sometimes it can be painful as well. This again is thought to be related to one of the medications that is used as an immunosuppression regimen. And again, oftentimes I have to use an oral medicine to help this. Another thing that many of us have experienced in our day-to-day life, so again, not unique to transplant, are Aphthous ulcers or Canker sores, and they can absolutely be annoying. And this is a condition that is often related to medications. And again, we see it in that couple weeks up to 6 months after transplant. This, however, has been associated with many of the drugs, not just sirolimus, but also everolimus and tacrolimus, as well as cyclosporin and mycophenolate. So that's, you know, a lot of the medicines in the arsenal of the post-transplant patient to help with rejection. Oftentimes we can work with a transplant team to come up with ideas on whether dose reduction can be helpful for this. Again, we do want to be very mindful that the point of the immunosuppression is to protect the transplanted organ, right? So we're not going to be recommending that the transplant team go off on a tangent of what they normally do for something like this if we can treat through the drug. We only really have the conversation with the transplant team if it's something that there's many factors to consider with their immunosuppression regimen they're prescribing. So these ones that are annoying things, usually we can treat through them, and then it doesn't have to alter your transplant regimen, but it does become a conversation. And this just speaks to why I think it's important to have somebody who is a transplant dermatologist involved in your care, because transplant dermatologists tend to know the transplant team. They tend to know the coordinators at their institution and other institutions, and tend to work very closely with them. It's very easy for me to talk to the transplant team at Hopkins for all of the organs about various patients of ours. And so I find that that can be very helpful for the patient's care when there's a conversation that happens between your specialists. And fortunately, the transplant physicians also know that I'm not asking for one very small canker sore for them to drastically change their plan. I'm only approaching them when I feel like we have exhausted our options to treat things. We try to be good stewards of the organ, just as you as the patient are. So fortunately with canker sores, there are topicals we can use. Usually it's a prescription steroid paste that can be quite helpful. With that said, I have had patients, it's just been intolerable. They have not been able to eat or drink because of how bad these are. And that was then a conversation with the transplant team. And we ultimately have been able to get those patients resolved just by tweaking a few things with their immunosuppression. Hair issues. This is one of the most common things that I feel like I hear from patients about in the first year after transplant. So it is extraordinarily common for patients to have massive shedding events, usually about 3 months after transplant. That condition is called telogen effluvium. It is not permanent hair loss, it is hair shedding. And what happens is, due to a stressful event, like a transplant, 3 months later, all those hairs have cycled into shedding phase. Now, just like the bulbs do in the ground in the springtime, the shedding event is temporary, and those hair bulbs will all regrow hairs. It just takes time. So I do a lot of hand holding in clinic for these patients of, you will get your hair back. You will not go bald from these shedding events. We can help with those. We just need the tincture of time to help with that. Now, interestingly, I've also had a number of transplant patients who have had very different hair texture after their transplant. So they may go through one of these shedding events, and then rather than having very straight hair, they now have very curly hair after transplant. It's fascinating to me, and I don't totally understand why that happens, but I have had that. Interestingly, that can also happen to patients that lose their hair from when they get chemotherapy for cancer, and they can grow back a different texture of hair. We're not exactly sure what the cause of that is. But in addition to hair loss that is related to the stressful event of surgery, you can have hair loss related to the medications. And tacrolimus is the #1 culprit in this, and that is the backbone for many transplant patients. Fortunately, as you can see in the photos, that woman was able to regain quite a bit of hair just by using topical Rogaine minoxidil. So that's what we typically recommend for patients to consider first if they're having this a hair loss event that we think is related to the medicine. The timing certainly helps us in terms of whether it's shedding event, like I talked about before, versus a medication-induced hair loss. On the flip side, cyclosporin is known to drive hair growth. And so for many parts of the body, that is fine for patients to have a little bit of extra hair. But obviously for women on the face, we wouldn't want that. And for this patient picture, their hand and their arm has gotten quite a bit higher density of hair growth due to cyclosporin. If it becomes an issue cosmetically for the patient, we can recommend doing hair removal techniques such as laser hair reduction, or also, shaving can be used as well, depilatory creams, as well as various other spa techniques that can help with hair removal. Another thing that's very common, a number of my patients, I end up pointing it out to them just so they know what it is on their skin, is this condition called sebaceous hyperplasia. Sebaceous hyperplasia is a condition of overgrowth, hyperplasia of the oil glands, sebaceous. So oftentimes patients come in and they're very concerned about these spots that they see on their skin. We tend to see these a year after transplant, going on far beyond that. This is an example on a patient that I had the opportunity to take care of when I was at the University of Pittsburgh. The red square on his cheek is a biopsy site from a biopsy for something else, but you can see that sort of spot that looks like it's just been placed right on the cheek that I have circled with the blue circle. That is overgrowth of the oil gland. We do have treatments for those. They are considered cosmetic, so usually insurance does not cover them. But we do know that cyclosporin and tacrolimus do drive this condition. And so I'm going to actually show you on the next slide. He actually has quite a few of them on his skin, and his other cheek was equally as involved. So oftentimes I point those out to patients when I see them in clinic, just so that they are aware of what they are. Another thing that's not worrisome, but is kind of a little bit gross to think about, is this idea of Demodex folliculitis. Demodex is a mite. It lives on all of our skin. It makes our residents very excited when we find one of these mites on a microscopy prep, because I'll show you a picture of them. They're fairly interesting looking to those of us that like to look at these things. Again, they live on everybody's skin, but in transplant patients, because there's a balance between their immune system function is no longer at its full capacity, you can get this reactive process to having these Demodex mites. You can also get this Demodex folliculitis without being a transplant patient. There's plenty of patients that come into our office with this. And the hallmark of this is it tends to be acne-like bumps, but they tend to be itchy, which is unusual for acne. Here's two patients, both transplant recipients, and you can see the woman at the top. It was sort of in her central face, her nose, her glabella, which is this spot between the eyebrows, and then the middle cheek. She has a lot of these like acne-like bumps. And the gentleman at the bottom, you can see his forehead, his nose are involved. And this in the second column, that is what the mite looks like. It has these little arms that come off. It looks like a little sea monkey creature or something like that. And that's not visible to the eye. This is a microscopy picture. But both of these patients, you can see, had great resolution. Typically, I use a topical medicine like permethrin, which is a topical antiparasitic, to help with this, or even an oral antibiotic can be helpful with the inflammatory response here. So I'm now going to move on and talk about some of the worrisome and annoying skin problems that patients can develop after transplant. So the first one I'm going to bring up is dermatophyte infection, and you know what dermatophytes are, even if you don't know the name. Dermatophytes is fungus of the skin. So athlete's foot, toenail fungus, ringworm, those are all forms of dermatophyte infections. And the reason that this is worrisome to us is not because the skin involvement is problematic, but if you were to have a high burden of skin involvement, we do worry that there's the potential that you could end up seeding a bloodstream infection. Now, anybody who has had ringworm or athlete's foot or jock itch can tell you it tends to be fairly itchy. And whenever you scratch something, you run the risk of inducing trauma to the skin, and trauma to the skin can be then an entryway for bacteria, or in this case, for yeast to enter into the body. And so we are very cognizant in transplant patients to be mindful that we should probably treat this a little bit more aggressively than we would in non-transplant patients. So here are some examples for you. The toenail at the bottom, you can see now if the condition is limited to just the nails in transplant patients, I am not very pushy in terms of treating them. The most effective treatment for toenail or fingernail fungus is an oral medicine. And typically that oral medicine is metabolized in a similar pathway as some of the immunosuppression medicines. So unless it's very bothersome to the patient or they're constantly getting skin infections on top of the nail infections, then I don't tend to treat that, because I don't want to give that medicine and potentially have to have the patient have their immunosuppression regimen monitored more closely. Now, with those caveats, there are plenty of patients that have been very disturbed by the look of their nail, or they continue to have issues with their skin being involved with the dermatophyte. And in those patients, I do approach the transplant team and talk about how we're going to monitor their immunosuppression levels while they're on the medication to treat their nails. The medication to treat the nails is typically for months to up to a year, and so it's not a short duration. You can see the picture of the gentleman is a patient I took care of who had just very extensive, it's called tinea corporis, or this would be ringworm, but all over the body, not just in that nice ring that we typically see. And then the picture to the right is a microscopic picture. That's how we usually diagnose this, is in the office, scraping some of the scale off of the skin and looking at it under the microscope. Another thing that I think of as being worrisome and annoying are warts. We tend to see warts a year or so after transplant. It is estimated that 50% of transplant patients will have warts 1 year after transplant. And if you look at a transplant patient 5 years after transplant, 92% of them will have developed a wart. So pretty high rate of forming warts in this particular patient population. And warts are driven by viruses that like the skin. And so it's not surprising at all that if you have immunosuppression in your system to keep your organ from being rejected, then you're going to allow or permit more viral things to happen. And so I think that's the #1 reason for the wart cause. Warts are super common in humans in general. It's not specific to transplant, it's just very high rate in transplant. So one of the problems with warts is that they can very much mimic one of the very common forms of skin cancer after transplant. And this is a patient that I took care of again when I was at University of Pittsburgh. He had had a lung transplant and had made a couple skin cancers after his lung transplant. And I think you may be able to appreciate that he has 2 spots, one on the outside of his left arm and one on the inside, or right at the base of the thumb there on the left arm. You could see them pictured there. They clinically look very, very similar. And so we biopsied both of them. That one on the outside ended up being a skin cancer, squamous cell carcinoma in situ. And the one on the inside is verruca vulgaris, which is the term for wart. So clinically, they can look very similar. So it's important to me that my patients that have warts keep an eye on their warts, but also that we look at them and that they're not just considered to be a wart by patient diagnosis, but that also the physician has looked at it and had a sense for whether they truly feel like it's behaving like a wart. I also tend to be a little bit more aggressive in treating warts in transplant patients because of this idea that they can look very similar to early skin cancers. And I want to see if they don't respond to therapy like a wart would, then maybe I have more of a reason to want to biopsy it or pursue a diagnosis other than wart. One great technology that has come out in the last 20 years has been the Gardasil vaccine for human papillomavirus. Now, Gardasil is a vaccine that was developed against the strains of human papillomavirus that drive genital warts and also cervical cancer. However, there is some evidence that vaccination against those will give you cross protection against the more common forms of HPV that can cause warts on the hands, the feet, other parts of the body. So, the indication for Gardasil has actually increased in terms of age for patients. So I've become more of a proponent for people to get the Gardasil vaccine. Again, the vaccine was never developed as a target for the strains of HPV that drive common warts of the skin. It was developed for the strains that cause cervical cancer, some penile cancers, oropharyngeal cancers, and genital warts, but we have seen in some patients vaccination to actually help with their overall wart burden in the more common warts. Okay, and so I'm going to spend the rest of my time talking about skin cancer, which is near and dear to my heart. That is the entity that I treat surgically during most of my clinical time, and that unfortunately a lot of our transplant patients deal with in their post-transplant course. So we tend to see skin cancers coming up usually a year and beyond after transplant, with the caveat that if a patient has had a number of skin cancers or even one skin cancer before transplant, it may not be that long after transplant where we start to run into issues with skin cancer. So transplant recipients get way more skin cancer than anybody else, and they get more skin cancer than any other group is susceptible. So this was a study I was involved with where we looked to see what is the incidence of getting skin cancer if you have had an organ transplant. And the incidence was 1,400 per 100,000 person years. And 100,000 person years means actually nothing to me. I don't know how to conceptualize that. So I went back to the literature and said, okay, we all know somebody who has had breast cancer. Breast cancer is so common. They quote it to say 1 in 8 women, right, will experience breast cancer in their lifetime. Well, if you put that in terms of person years, that's only 120 per 100,000 person years. So skin cancer in transplant recipients is actually 10 times more common than breast cancer. And we all know somebody who has had breast cancer. Lung cancer in current smokers. So the highest risk group for getting lung cancer is still just 300 per 100,000 person years. So again, much lower than the incidence of skin cancer in transplant recipients. So if you walk away from this presentation with nothing else, I want you to know that as a transplant recipient, you are at a much higher risk for skin cancer. There are absolutely things we can do to decrease that risk, but just being mindful and not letting things fester can make a huge difference, a huge difference. So melanoma is the flagship skin cancer that gets all the press. In fact, it is May, which is Melanoma Awareness Day, and the Friday before Memorial Day is always the dermatologist's banner day for patient education, which is No Fry Friday. Wear your sunscreen when you're out on that boat on Memorial Day weekend. So this is a melanoma that I actually saw in a heart transplant recipient that I had the opportunity to take care of. And you can see it was quite large, quite large. Fortunately, he actually did quite well from this. But melanoma is the cancer of the pigmented cells. So melanomas tend to be dark. They can be pink, that's pretty rare, but they're dark. They can look like moles initially. And we know that if we detect these early, before that they have spread deep, before they have gone to other places, the survival is quite good. We know that UV radiation from either sun or tanning beds is what drives this cancer. And this is what's traditionally taught, the ABCDE. If you have a mole that is asymmetric, not the same on both sides, has a border that's irregular, has different colors in it, or is super dark when all your other moles are light, or has a large diameter, they say bigger than a pencil eraser. This gentleman's was 2 inches, so clearly bigger than a pencil eraser. But the biggest thing for me is if a mole is changing, because no moles should be changing in adulthood. So you're allowed to get new moles into your 20s and 30s. You can have a little bit of change and it not be worrisome to us, but if you notice, if beyond your late 20s you notice new moles, or if you notice any mole changing, that warrants a trip into your dermatologist so that he or she can take a look and tell you whether they think it is okay or not. Most commonly, patients come in with changing moles for me, and they actually aren't even moles, they're something else. But I would like to make that decision. I don't want the patient to make that decision that it is fine and not a mole if there's the potential for it. Squamous cell carcinoma is the type of skin cancer I treat most commonly. So it is far more common than melanoma. This is the most common skin cancer in organ transplant recipients. It is a cancer not of the pigment producing cells, but of the rest of the cells that make up the skin, the ones that make the majority of the skin. It can be waxy, scaly, yellow, red. It can be an ulcer that doesn't heal. It can be a bump I tried to squeeze. It can be a bug bite that didn't go away. It can be I bumped my forehead on the car door and then now this hasn't healed. All of those are things I have heard related to squamous cell carcinoma. On this particular gentleman that you see with the nasal cannula here, it's that yellow scaly spot that's on the side of his nose. These are almost always in sun-exposed areas, with one exception. You can have squamous cell carcinoma in the genitals. So the penis, the scrotum, the perineum, and the perianal area also can make squamous cell carcinomas. So we have that sun-exposed side and then the non-sun exposed side. So on the sun-exposed side, I commonly are treating these on scalps, faces, necks, forearms, and hands, and in women more than men on the lower leg. This is a gentleman who was 56 when I first met him. This is the first time I met him. He had had a renal transplant a number of years ago. He had been maintained on his immunosuppression regimen. And unfortunately, when I met him, he had 24 spots that looked like squamous cell carcinoma. Now, obviously, he had not seen somebody about these. These did not pop up overnight. They were slow. They're not the slowest growing thing, but this is not going from normal skin to this in a week. This would be over the course of months to up to a year. So we slowly worked our way whittling through some of these various spots. He has some examples. If you look at the picture that's forward, you can see he makes a little of these cutaneous horns that can be an indicator, but also some of them are just red and scaly spots on him. This is a gentleman who had had a lung transplant, was in his mid-60s, and here's an example of a squamous cell carcinoma on his shoulder. And here's a woman, also a kidney transplant in her 70s. She has had, she had many years of sunbathing at the pool with her legs out, and her legs were showing us all of this damage now. This is a good place to talk about the fact that we can't change historical damage that's been done. So this woman was not still after transplant sitting out in the sun. We were doing a lot of catch up of the sun exposure she had had throughout her life. We know that the immune system constantly surveys the skin for atypical cells and early skin cancers. And so when you reduce your immune system so you don't reject your organ, then a lot more of these are able to persist and go on to develop skin cancers. We've lost that surveillance of the immune system. There's a lot of things we can do to try to prevent that. And of course, treat it once it comes up. But we do try to employ a lot of preventative strategies. So here are my recommendations for skin cancer screening. At minimum, every 2 to 3 years with a dermatologist. Of course, that depends on the organ that you receive. Our kidney transplant patients tend to be lower risk than our heart and lung transplant patients are for skin cancer. Our liver transplant patients tend to be more like the kidney transplant patients and less like the heart and lung patients. But I do have patients with every one of those organs that sees me every 3 months because of how rapidly they develop skin cancers. So it's very individualized based on what your skin looks like, your history before transplant, what organ you have, and what immunosuppression regimen you're on. If you have skin cancer prior to transplant, you're almost always seeing me more frequently than if you didn't have a skin cancer prior. The skin has different phototypes. This has to do with how easily you burn or tan. Many of the patients that I have shown pictures of are this type 1, which we typically think of as the red head that's covered in freckles. Always burn, never ever tan. They go from white to red to white. Then you have patients that have skin sort of like I do, very fair. We burn very easily, but the burn becomes brownish. And then we go back to the white color. And then if we went out again, we would get burned again. We have patients that tan after initial burn and then just tan. We have people that burn minimally. We have people that tan very easily. Then we have the rare burners, tan dark very easily, and then always tan. So if you are the skin type that is type 1, where you always burn, your risk is much higher. If you're skin type 5 or 6 and you get darker, but you don't really burn, your risk is much lower because that pigment is protecting your skin, the pigment that you naturally have. Now, anytime that your skin gets darker, whether it gets red or tan, that is evidence that the skin is being damaged by the sun. So going out to get a tan is not good for your skin. It is damaging your skin and it doesn't protect you. Your protection comes from your native amount of pigment you have and then whatever you put on top of that. So here's what I'm going to talk about. This is my son from 2 years ago on the Patuxent River. This is what a dermatologist kid looks like. You can pick them out in a crowd. They have a wide brim hat on. They have zinc-based sunscreen. That's my favorite type of sunscreen to use because you can see it. And he still lets me put that on him. In fact, he started to get better at putting it on now. And then I love, love, love UPF clothing because then I don't have to worry about sunscreen. As long as you keep those sleeves down, then you are covered and protected. You don't have to reapply the sunscreen. That is the blocker of the sun, but long sleeves is what it needs to be. Quickly, I want to talk about how to read a sunscreen bottle. It's important to look at the SPF. I recommend 50 for all of my patients because most of us, myself included, do not use enough sunscreen to get the number on the bottle. So I feel like if I use 50, I probably am getting 30 worth of protection. You want broad spectrum, which means it covers both UVA and UVB. Those are both important. And then you want water resistant, especially if you're going to do anything where you're sweating or in the water. None of those mean that you don't have to reapply. every 2 hours is when you're supposed to reapply. In fact, in the beaches in Australia, there's a little chime that goes off every 2 hours to remind you to reapply your sunscreen. Australia has a super high rate of skin cancer. And I think everyone would be surprised to know how much sunscreen you need to cover your body, which is, that's not a beach body, that is a clothed body. You still need a full shot glass worth of sunscreen, a whole ounce to cover the exposed skin. So like I said, SPF 50, I like the mineral-based ones. I have a handout with different sunscreen recommendations that I've provided. I love those sticks for the face. I hate the spray. Nobody rubs the spray in. Half the time you can see the speckle on their backs from where someone sprayed it, and then the person walked away and they got burned where there were no speckles from the spray. I also don't like whatever is accelerating the spray to get it out, especially with kids. The American Academy of Pediatrics has really shied people away from using that because of inhalation of the particles. So again, I like the stick. I do not like the spray. If you do choose to use the spray, you do need to rub it in. It's not spray and go, it is spray and rub. Here's two examples of sun protective clothing. The first one is the hat that I exactly bought for my son, and we'll be buying another one this year from Sunday Afternoons. I like it because it has a wide brim. You want a 3-inch brim for your hat, and it has this extra flap in the back that covers his neck. So I like that. Actually, my mother got one very similar to it for when she's out in the garden. To cover the back of her neck. It provides great shading in there. And then a patient of mine clued me into this, these Hanes products that are on Amazon. I'm sure you could get them elsewhere. Amazon seems to be easy to order from, but this is the screenshot from that. And I thought this was a really good deal. For 2 of these long sleeve UPF 50 shirts, $20. That's pretty good. They come in lots of colors. Okay, with that, let me get out of this and see if I can get to the...
Dr. Bybee, I'm going to go ahead and read our first question since we're almost at time.
Yes.
The first question was submitted. If I use sunscreen near or above my eyes on forehead, then the sweat makes it go into my eyes, making them burn. Is there a sunscreen that does not burn your eyes?
So mostly what's burning your eyes is what is in the sunscreen other than sunscreen. So I think that you could absolutely try the zinc and titanium products, which are the physical blockers. If you try one of the sticks where there's not much in it other than like a little bit of wax to be able to apply it, that can be very helpful. Hats that cover your forehead and physically block the sun from getting in there are also great if you have a problem keeping sunscreen on your forehead. I see a lot of people, especially women, that like to wear visors, but remember, visors don't cover any of this. So really hats are where I would go for that. And just be mindful, if you're on the water, the sun reflects up from the water, or if you're on snow, it reflects up. And so then the hat's not going to give you as much protection. But I would try the physical blockers instead of the chemical blockers for that problem.
And Dr. Bybee, we have time for one more, so I'm just going to choose the next question, which is, how do I know if the hair loss I am noticing is a shedding event versus tacrolimus?
You need to see a dermatologist. We usually will, we can evaluate and look at the scalp and also the hairs that are shedding, and usually can have a sense for it as long with the timing. So I'd recommend that you would come in and see somebody.
Okay, so I am going to make a general announcement because we are almost at time. There are several of you who have posted questions. I will have Dr. Bybee follow up with you with answers, but I wanted to put in the chat box right now the general meeting Zoom link. So if you can please access that now from the chat box. Dr. Bybee, do you have time to pop into the general meeting room?
I do not, but I can, if this stays on, I can answer these questions. I can like type answers to them, I think.
Okay.
Is that possible?
Yeah, that's possible. I can keep this room open for another, I'll say till like 11:01, but I do have all the questions here that I'm going to make note of. And then that way we can post those maybe with your handout as well.
Okay.
Okay, so I'm going to go ahead and do that. And then just two more items before we close today's room. For those who want to connect again with other participants, the general meeting room is open. You can log into that Zoom room link that's in the chat box. And Trio Maryland will be announcing our t-shirt raffle winners during our closing session. So please make sure to join us. So I'm going to keep this room open for about 1 more minute, but this concludes our session and we will see you at our next session.